Hi, I'm Jihan Kim, and I'm here with 3M Healthcare Academy to talk about direct restorative solutions for black triangles using injection molding and the BioClear method. Some of the learning objectives for this webinar are to understand different types of black triangle cases appropriate for the black triangle kit, proper case preparation, isolation, tooth preparation, matrix selection and placement. Also understanding the elements of injection molding, and so with that we'll cover the specific steps of the injection molding at the end, and some of the benefits of injected versus hand-placed composite resin. Understanding a much simplified polishing method, so our Rockstar polishing steps for biofilm and stain-resistant restorations. So this webinar is sponsored by 3M Oral Care. So let's go ahead and get started. There's basically 3 chapters to this webinar. The first chapter, understanding black triangles. Then we're going to talk about case preparation. And then finally, injection molding, finish, and polish. So understanding black triangles. So there are multiple factors that contribute to the formation of black triangles or open gingival embrasures. So some of the periodontal concerns contributing to black triangle formation would be loss of interproximal bone height, and that can occur just with age. It can occur with attachment loss from periodontal disease, surgery, or trauma. Some orthodontic considerations would be unfavorable root angulation or wide intraradicular distance that's going to lead to those open gingival embrasures, and also a more tapered crown form that's going to create those open gingival embrasures. One of the things to consider today with the advent of a large number of adults undergoing orthodontics is that with adults, the periodontal complex doesn't move the same as with young adolescents. And so oftentimes adults undergoing orthodontics will have some black triangles that will form, potentially up to 40%. And the irony is that some of these adults are undergoing orthodontics to actually treat some small black triangles that they're seeing. And so I think that this is something that potentially can be informed consent issues. So if you do have an adult patient that will be undergoing orthodontics, then I think that to discuss black triangles with them and the potential for black triangle formation is going to be important. So when we think about some conventional solutions to black triangles that we've had in the past, so we have orthodontic repositioning, basically extrusion of the teeth in order to move incisally the interproximal bone, changing root angulation issues or correcting root angulation issues. We also have interproximal bone graft, which is not really a very predictable solution unless you have maybe a very minimal defect and support by at least 2 to 3 walls of bone. We have soft tissue graft or papilla reconstruction, which again is can be unpredictable because it's really dependent on interproximal bone height. We also have something that's a little bit more new now is injectables to plump up the papilla. But with that, it's something that requires continued maintenance and repeated treatment. We also have indirect restorations, which is would be a subtractive method where we need to actually remove tooth structure in order to deal with path of draw and path of insertion issues in order to fit an indirect restoration around the tooth to get into those undercuts to treat the black triangles. And then, of course, we have direct hand-manipulated pink or white composite resin solutions as well. So I want to talk about the difference between black triangles treated with layered hand-manipulated composite versus injection molding. What you see here in this in this case, which was actually treated with cold composite and a flat mylar matrix, you can see the lumpy composite and the overhang here, and which has already collected some biofilm and stain. Now, the ironic thing is that from the facial surface, the patient was actually happy with the black triangle treatment because it did do the intended, it had the intended result, which was to manipulate the tissue in order to close that space. Now, if you look at the radiographic appearance, you can see that what we actually have is what looks to be a large overhang, subgingival overhang. And so the tissue, the way that the tissue was manipulated or the way that the tissue responded was probably more of an inflammatory response that then closed that black triangle. So it's not really a favorable outcome. Now, here's a case that was contributed by Dr. Charles Regalado, and this was a black triangle treated with an indirect solution. So this patient had large black triangles in the lower anterior area, and he also had some coloration issues and desired to have these aesthetically rejuvenated. Now, if you look at the preparation that had to be performed on these teeth, you can see that there was quite a lot of tooth structure that was sacrificed, again, for the path of insertion and draw issues. And especially on those lower anteriors with the smaller teeth, and it's not necessarily something that we like to do because of the great volume of tooth structure that has to be removed. If you look at the final restorative outcome, you can see that it was a very nice solution. The black triangles were treated, the coloration issues were resolved. But then again, one of the things that can happen over time is that, with continued gingival recession, those black triangles may again open up. And now we've sacrificed tooth structure. In order to retreat them, we would be considering sacrifice of even more tooth structure. Another potential disadvantage is that, with the potential abrasiveness of these ceramic restorations, if they're opposing natural dentition, then there's a possibility of some unfavorable tooth wear or increased tooth wear. So let's compare that with black triangle treatment with injection molding. Now, the advantages of injection molding is that it's an additive treatment, and so it's non-invasive. And generally, we are not talking about any tooth structure removal in order to do this treatment. What we get with the BioClear matrices, which are the first clear anatomic matrices available, is that we get the smooth subgingival contours, which really promotes good tissue adaptation and health. So the BioClear anatomic matrices will create the contours in the subgingival area and in the interproximal areas, which are the areas that really are difficult for us to access for polishing and contouring. Now, the advantage of the mylar finish is that we get reduced biofilm and stain accumulation. And also with that, we get reduced calculus accumulation, and if there is any calculus that accumulates, it's very easily removed. Now, another advantage, which is kind of new, is that with injection molding and with these black triangles treated, we're creating broad incisal-gingival and buccal-lingual contacts, which can lend to orthodontic stability. So a lot of these patients, especially on the lower anteriors, if they have small point contacts, generally, we always have them wear either a fixed retainer or a clear orthodontic retainer just to help with retention. And what we're finding with a lot of these patients is that usually we can forego any sort of retention because of the broad contacts that are created. So here's a case that was treated with injection molding in the BioClear method. And in the top preoperative photograph, you can see that this patient also had the large gingival embrasures, open gingival embrasures, and he also had some coloration issues on the gingival half of those teeth. And so he wanted an aesthetic treatment for these areas. Now, on the lower image, you can see the immediate postoperative view. So you can see that the color was masked, and also those open gingival embrasures were closed. And you can see the nice soft tissue response, even just in the immediate postoperative photograph. Now, what's really impressive with injection molding in the BioClear method is actually the radiographic, postoperative radiographic appearance. And here, unlike the result with cold composite and with flat mylar, you can see the smooth subgingival contours, which really lends to good tissue adaptation and health. So when we're closing these black triangles or these open gingival embrasures, now as dentists, we might be thinking about microaesthetics, so the balance between pink aesthetics and white aesthetics. And so in the preoperative view, you can see the large black triangles. In the postoperative view, you can see that those black triangles were closed. Now, when we start thinking about contact length, so we can see on the postoperative view with the red hash lines, which is showing the ideal contact lengths, that those contact lengths have been, they're not ideal, they're long, but the question is, which concern do patients consider to be worse? So are they willing to accept the longer contact lengths for a very conservative treatment outcome? And most of the patients, really do, because if we think about, how our vision works, so what we really focus on are stark contrasts between black and white. And soft color contrasts are much more acceptable. And so when you consider some of the treatment options in order to idealize those contact lengths, which would potentially include tooth structure removal, but then also additional orthodontic treatment with extrusion. I've never had a patient that was unhappy with black triangle treatment in this way, and they were willing and quite happy to accept the compromise of a longer contact length for a very conservative treatment. So now let's think about case preparation. So as I said, the BioClear method and using injection molding to treat these black triangles, it's an additive procedure, so we're really not sacrificing any tooth structure. So the way that we prepare the teeth is really by disclosing the biofilm and making sure that we remove all of the biofilm prior to the injection molding process. So I want to focus on, we have multiple matrices with the black triangle system within the black triangle family that can be used for black triangle treatment, but I want to focus in this webinar on BioClear's new black triangle kit. So the black triangle kit comes with a black triangle gauge, and so we'll talk about how to use that gauge in matrix selection, and we'll talk about trying in the matrices prior to rubber dam isolation and the importance of that. Now, as far as case preparation, we really strongly advocate for rubber dam isolation for really good soft tissue isolation and retraction. And we'll also talk about biofilm removal with disclosing and blasting, and then just managing the interproximal contacts for matrix selection, or I'm sorry, for matrix insertion. So the black triangle kit gauge, it has four colored zones, which correlates to a matching colored large or small incisor matrix. So you can see here that there's a red zone, a yellow zone, a green zone, and a blue zone. Now, the large incisor matrices are really for maxillary central incisors and cuspids, and the small incisor matrices are really ideal for maxillary lateral incisors and mandibular central and lateral incisors. Now, I talked about trying in the matrices prior to rubber dam isolation. I'll show you kind of the reason why that's important. So in this photograph, you can see that we have a black triangle between the central and the lateral incisor, and I'm going to show you what it looks like with some of the matrices inserted. Now here with the matrices in place, what I'm looking for is minimization of that black triangle, at least 85, 90%. So we still have a very small residual black triangle, but you can see that there's tissue blanching here. So in this case, I know that with this small residual black triangle, that because I have this tissue blanching that I'm still placing some lateral pressure on the soft tissue, and I'll get further tissue adaptation with time. So really what we want to try to avoid is overclosure of these gingival embrasures and choking at the papilla that can cause some chronic inflammation as well. Now here you see the black triangle gauge in use in a clinical case, and you can see that with the black triangle gauge in place that it's somewhere in between the green and the blue zone. So in this case I would want to try in either a green matrix or a blue matrix and then select the matrix that best fits the clinical case. So here you have the black triangle matrix, the entire black triangle matrix, and so you see the black triangle gauge with the 4 colored zones. So you also see the small incisor matrices, which have the 4 corresponding colored matrices, and the large incisor matrices, which also have the 4 corresponding colored matrices. And you see a small vial of some disclosing solution to reveal the biofilm, and then the true contact sanders, which we'll talk about next. So here you see one of the true contact sanders used to idealize the contact tension prior to matrix and solution. So there are 3 contact sanders. There's a blue sander, which is safe-sided, and we use that primarily to remove any calculus, any debris prior to rubber dam placement to avoid damaging our rubber dam. There's also an orange sander, which is single-sided, and we will always use that just to, again, idealize the contact tension, but also to remove any stain or biofilm from the contact prior to placement of the matrices and injection molding. Sometimes we'll use the red sander, which is dual-sided, such as in this case, to be a little bit more aggressively manage the tension of the contacts. And here you see the clinical case with a series of 4 matrices in place. At the midline black triangle, you can see 2 matching red black triangle matrices. And at the black triangle between the central and the lateral incisor, you can see a mix of matrices. Now, the reason for the mix of the matrices here is to make sure that we're selecting the right size matrices to adequately close a black triangle while maintaining a vertical line between the central and lateral incisor. So what we want to try to avoid is avoiding introducing a cant between the teeth. So let's look at a video for biofilm removal. So the question that comes up a lot with the clinicians is, well, doesn't acid etch effectively remove biofilm? So here you see the biofilm, which has been shown by the disclosing solution, and then acid etch is applied. And so after the 20-second acid etch, it was rinsed off. And what you can see is that the only thing that the acid etch did was to actually change the color, but it still left the soft biofilm on the tooth. So acid etch will remove the mineral component, but acid etch will remove the inorganic component, but it will not remove any organic components, which is the biofilm. So the blaster here, we're removing biofilm with aluminum trihydroxide, which sounds similar to aluminum oxide, but it's much softer, so it safely removes the biofilm without etching your ceramic restorations or etching the enamel or removing the finish off of your mirrors. So let's talk about the shape of black triangles and matrix selection or mixing and matching of matrices. So on this left image, you can see the midline black triangle, and you can see it's an equilateral black triangle. And so in this case, because the black triangle is symmetrical, I would be choosing 2 black triangle matrices that are the same size. Because what I want to do is to evenly distribute this black triangle between 2 teeth in order to maintain that vertical line and also to close it effectively. On the right image here, you can see a black triangle that's asymmetrical. And in this case, I would be mixing and matching matrices. So in this case, what I want to do is to add more volume to the mesial of the right central incisor, mandibular central incisor, and then add a little bit less volume to the mesial of the left central incisor in order to make sure that I'm still closing that black triangle adequately, but still maintaining a nice vertical line between the teeth. So let's move on to injection molding, finish, and polish. The things that we're going to cover here are basically some of the benefits of injection molding versus hand placement, heating of composite, the injection protocol, and then also talking about our simplified finishing and polishing steps and the benefits of a mylar finish. Now, just to give you a quick analogy for hand-placed cold composite, so here's a pretty lumpy, bumpy road, patchwork road on an island. And this is analogous to what we do when we hand manipulate and place cold composite in a patchwork manner. So this is a young patient that had some undersized lateral incisors treated. And you can see this this right lateral incisor, which has been treated with flat mylar and cold composite. And what I want you to see is actually just kind of the two little center areas. That's actually concavities that were placed in the composite to mimic the natural undulations on the facial surface of the teeth. But you can see that when you don't have a really smooth or highly polished composite, and if you create concavities, that it tends to accumulate biofilm. And in this case, the biofilm was there long enough that it actually started to calcify and become tartar. You can see the radiographic appearance here and how what we have is the big overhangs interproximally, which again is not ideal for tissue health. Now with part of the injection molding protocol is to use warmed composite. So 3M has done a lot of studies with their new Filtech Universal restorative capsules, and what they're confirming is that the physical properties of the composite doesn't change when warmed. The advantages of warmed composite is reduced hand strain because it lowers the extrusion force required to extrude the composite by 75 to 80%. And I know a lot of clinicians will have concerns about the use of warmed composite as far as pulpal response. And the warm composite really transfers minimal heat to the pulp, mainly because it's a pretty poor thermal conductor, but it also has low specific heat. So it doesn't carry much heat, and it also doesn't transfer heat very well. And really the only time that we need to be concerned about pulpal damage would be if we're introducing something or if we're doing something to generate enough heat to increase the pulpal temperature by about 5 to 6 degrees. Heating of the composite doesn't do anything as far as the biocompatibility of the composite. And what they've seen is that the capsules can be warmed So again, composite warming, some of the benefits are just, it gives you the decreased viscosity, which is better for injection molding, and basically better feel to your hand because it requires less extrusion force, and so it leads to less hand strain. And it's actually not so uncommon anymore. There's, 14% of dentists actually will do some sort of heating of their composite, and it's something that a lot of clinicians have been playing with off and on for a number of decades. So more and more clinicians are starting to accept the benefits of heating of composite. So BioClear, what we use is our heat sink composite heater, and the benefits of this compared to some of the other heaters out there is that just the volume of composite that we can heat at one time. It does maintain the temperature of the composite to 155 degrees Celsius, 155 degrees Fahrenheit, which we found to be pretty ideal as far as the change in viscosity of the composite. And it also has an oven to store more compules, especially when you're doing a lot of injection molding is a really nice feature. Now, when this photograph is really to give you an idea of what injection molded composite is like. Instead of the patchwork road, what we have is a very smooth, continuous pavement here. And this, when with the injection molding with the dual viscosity composites, we're able to create a monolithic composite form around the tooth that then we shape back and create a restoration which has really good long-term stability as far as stain resistance and aesthetics. So let's look at some of the potential longevity for injection molded restorations. So here's a preoperative view of an undersized lateral incisor that's about to be treated. And then here's the 8-year follow-up. And we actually have a 10-year follow-up as well. But I know that some of the concerns with longevity of composites is, some of the complaints I've heard are that we have color stability issues, or that we start to get staining or ditching of the composite. And so what you can see here is a very monolithic, color uniform, color stable restoration. And again, what we always like to see is the postoperative radiograph and just the smooth subgingival contours and how these restorations hold up really well over a long period of time. So let's look at injection molding, just a small snippet of what the injection molding process is like. So here we have a tooth that has the anatomic forms on the mesial and distal, basically around the tooth, and we're basically going to acid etch the entire tooth for 20 seconds. Now this video has been sped up a little bit. After that, we're going to rinse and dry. And if you need to do an immediate dent and sealing, we're going to do that by applying adhesive, earthing it, and curing it as needed. And then the first step of the injection molding process is to wet the entire tooth with adhesive, earthen that, but don't cure, followed with flowable composite, and then here we're following with immediately with heated regular composite. Once the entire tooth has been injection molded, we're going to readapt the shape of the matrices, do a little bit of some gingival cleanup with some dry brushes, and then cure. Now we're going to do 3-point curing, 20 seconds on the facial, incisal, and lingual. And then once we remove the gross excess, we're going to re-cure. So some of the benefits of mylar finish composite resin, we'll just go ahead and review that. So composite resin just naturally, it has a surface energy and roughness that tends to attract more biofilm than enamel. But the finishing and polishing procedures really impact plaque accumulation on resin-based composites. So if you recall that young patient that had the undersized lateral incisor treated, that composite restoration, it wasn't highly polished, and then because there was some surface texture that was created with the undulations, there was some biofilm that was collecting on the facial surface of the tooth. So composite resin surfaces that have a mylar finish reestablished, though, are very similar to enamel in terms of bacterial accumulation, and they also tend to have better abrasion resistance. So basically what that really means is that the advantages of the mylar matrices and the Rockstar polish, which essentially recreates a mylar finish, is that we get reduced biofilm attraction, we get increased stain resistance, we get good color stability because these restorations, they lack microsurface texture that can accumulate stain and biofilm. As far as shade selection is actually more predictable because we know what our final restoration finish is going to be. And so the way that we do our shade selection is that we do a little button of composite, we place a mylar strip over that, press it, cure it, and then we know what our final shade is going to be. With the mylar finished restorations, we get really beautiful reflectance of light, so the specular highlights, which are the little points of light that actually bounce off the surface of the tooth. And we also get kind of what I like to call non-layered polychromaticity. So if you think about when you crack an egg and you have an egg white, when it first comes out, it's quite translucent. And then the more air that you introduce or you whip into the egg whites, then the egg white becomes more white because of more frothy appearance. So if you think about that in terms of our composite restorations, the more that we manipulate it, the more defects and the more air that we're incorporating into those composite restorations, we're actually increasing the value, and we're taking away from the natural opacity or translucency that the composite actually has. So if we don't manipulate the composite too much, and if we don't introduce a lot of air, then we get the benefits of a nice translucency that allows some of the underlying tooth coloration and character to come through. So we actually can create some polychromaticity on these teeth, on these restorations, but just in a really safe way as far as longevity for the restorations because they're monolithic. If you want to hear a little bit further discussion about some of the concepts of specular highlights and color selection, non-layer polychromaticity, you can actually refer back to a different earlier webinar that I did talking about creating microaesthetics on anterior restorations with direct composite restorations. So let's go ahead and review the adhesive and composite products that we're using in injection molding. So we really like 3M Scotch-Bond Universal Restorative because it just fits the method. We want a one-bottle system just in terms of for the injection molding procedure, it just works really well. We also like the 3M Filtech Supreme Ultra Flowable because that flowable shade matches with the corresponding Filtech Universal Restorative compule shade. So it's a really good match. So for injection molding, which is basically using flowable composite followed immediately by the regular composite, you want the two colors to match. For the finish and polishing steps, we use the Softflex finishing strips in the disc. So I will actually use the large coarse discs for most of the shaping. As I continue to use that disc, it actually becomes multiple tools because of the abrasive declines, and then the disc becomes a little bit more supple. So I'll use that same disc to the finish of the restoration, and as the disc becomes more fine in terms of the grit, the surface texture of the restoration is refined. So then I can just move straight on to BioClear Magic Mix, which is multiple grits of pumice within a suspension, which then refines that surface texture even more. And then we finish with the BioClear Rockstar Polisher, which is a diamond impregnated polisher, and then gives us that wet glass appearance to our restoration. So this is, with these three steps, that's how we recreate the mylar finish, the mylar surface on our composite restorations, which gives us all the benefits of reduced biofilm accumulation, increased stain resistance, actually increased abrasion resistance, and then also just the nice aesthetics and the polychromaticity, the non-layered polychromaticity. So let's go ahead to the next section of the webinar, which is going to be about a 15-minute long start to finish introduction to the Black Triangle kit. So introducing you to the components of the kit and how to use each one, talking about how to use the Black Triangle gauge, matrix selection, matrix placement, and then also going through the steps of injection molding. Hi, my name is Dr. Jihan Kim. I'm a faculty member at the BioClear Learning Center, and today I'm going to introduce you to Black Triangle treatments using BioClear's new Black Triangle matrix kit. So I want to introduce you to the different components of the kit. So there's the Black Triangle matrix system, which is a new prescriptive matrix kit. You should also find a soft tissue dental form, which is going to be important to simulate tissue responses to the lateral pressure provided by the matrices. We're also going to be using Scotch-Bond Universal Self-Etching Adhesive and Filtech Universal. We'll be using the LFR 3M's light, curing light, which is important just for making sure that we get good depth of cure. We'll be doing biofilm removal with the BioClear blaster, and within that blaster we'll be using aluminum trihydroxide powder. And for finishing, we'll be using Magic Mix, which is an aluminum oxide mix, and then also the new Rockstar polisher. Now, to do a predictable black triangle closure, it's really important to have well-heated composite. So what's very important to our injection molding technique is to use our BioClear heater, which is going to maintain a uniform temperature at 155 degrees Fahrenheit. Please make sure to turn your heater on now because it will take about 15 minutes for the heater to warm up. Chapter 2, Case Prep. So I want to talk about rubber dam placement for best practices. Now for black triangle treatment, we do recommend rubber dam placement because it does help with soft tissue isolation and just for sealing of the roots of the teeth. So remember, we do want to always select the matrices. So we want to use a black triangle gauge and we want to select the size of the appropriate matrices prior to rubber dam placement. But once that's all done, then we'll go ahead and do rubber dam isolation. So let's talk a little bit about rubber dams. So what we have here is a properly stamped rubber dam. And so you can see it has a maxillary and a mandibular arch form. Now what's important is that you use a stamp that is pretty well centered within the rubber dam, and that you use a rubber dam punch, and the size of the punch is going to vary depending on the root size. So you're not going to necessarily alter the spacing of the rubber dam punches, but you will change the diameter of the rubber dam punch for each appropriate root. So there are 3 sanders. The blue sander only has a serrated edge. It's non-cutting on the sides. Now this is a great sander for using as a scout, just to clear the contacts. It's also a great sander for using to remove cement that's cured in between the contacts. The orange sander is single-sided. It's only cutting on one side. The red sander is dual-sided and is cutting on both sides. So once we're done with the blasting, what we're going to do is to use the sander to fully clean the contacts. So typically what you'll do is to use an orange sander first, and you'll clean each contact area. Now these sanders can also be used to manage the tension of the contact if you're finding that matrix insertion is difficult. So once we've cleaned the contact, we're going to reinsert our matrices. So remember, you're going to insert it at a slight angle, inserting it into the incisal embrasure space. And again, you're going to use the incisal edge of the matrices as a visual cue as to whether or not those matrices are seated equally. We're going to use the large green matrix on the distal of the central incisor, and then the small green matrix on the mesial of the lateral incisor. Now to reiterate, these black triangles are symmetrical in nature, so we're going to be using identical matrices. So 2 blue matrices for the symmetrical midline black triangle, and then 2 green matrices for the symmetrical black triangle between the lateral and the central incisor. If you have an asymmetrical black triangle, you may want to mix and match the size of the matrices in order to maintain a vertical line. So now we're going to come in with our Scotch-On Universal and wet the entire tooth. In this case, we're not concerned about any dentinal sensitivity. So we're just going to wet the entire tooth and make sure that we're completely air thinning our unfilled resin. Now we're going to come in with our heated flowable composite. You're going to reflect the matrix and take the tip as far to the palatal and gingival as possible. The key to injecting with heated composite is to inject slowly and steadily. You want to completely fill each embrasure space, allowing the flowable time to wrap around to the palatal surface. Try to avoid locking the tip of your syringe in the embrasure space. Make sure you fully line each embrasure and each contact area. Okay, now we're going to come in with our warmed regular composite. Make sure you extrude a little bit of the composite to eliminate the airspace. You're going to peel open the matrices on the facial and travel down towards the gingival facial of that tooth and begin injecting at the gingival perpendicular to the facial surface. While you're slightly pivoting the orifice of the compule side to side, you're going to travel towards the incisal. As you reach the incisal edge, you want to pivot the tip to inject perpendicular to the incisal surface. Assess the shape and the monolithic nature of the fill prior to curing. You want to cure from the facial for a full 20 seconds. You're going to trim the incisal for a full 20 seconds. And then you want to cure the palatal for a full 20 seconds. Once you're fully cured, go ahead and remove the matrices off of the other teeth. And then using the Explorer, you're going to peel away the matrix. Make sure you fully release it below the contact. Then you'll grab each matrix with the hemostats and spin it out. Okay, Chapter 4, finishing and polishing. So once we're done with the injection molding, we're going to do the amputate the gross excess and then move on to disking and polishing. You're going to want to use a coarse flame burr. And we do our amputation and our disking dry. So what you want to do is to go ahead and amputate the incisal excess to about 1/2 millimeter of the final incisal edge. Now we're going to amputate the facial excess, cutting through the mylar finish zone instead of the oxygen inhibited zone. Now I'm going to switch to a football diamond or a football carbide. And we're going to recreate the palatal fossa, staying away from the line angles. We can get a little bit of finishing of the palatal fossa area with a brownie, using it at medium speed and again dry. Now we're ready to finish the shape with our disc. You're going to grab a large soft flex coarse disc. Straight out of the box, you're going to use it facing out, and you're going to bring that first to the incisal edge and bring it down to the final length. You're going to use that same disc, which now has even more flexibility, and you're going to blend the gingival half with the incisal half. Let's evaluate from the incisal. So you want to note that we have a uniform surface texture with absence of white lines or white spots. Those would be indications of really deep scratches or indications of bubbles. Now we're going to move on to the magic mix. So we're going to go ahead and dispense some of the magic mix, which is a mix of different grits of pumice. And you want to use the magic mix with the white rubber cup. Get a pretty generous scoop. And you're going to go ahead and put this on the tooth, and you're going to massage it into the surface of the tooth for at medium speed and medium pressure. Occasionally you're going to scoop up more of the magic mix. Go ahead and grab your gray diamond impregnated Rockstar polisher. So first we're going to start. Well, I hope you enjoyed that video, which talked about the black triangle kit and taking you through each of the components, and then walking you through injection molding, and then also the finishing and polishing steps. So just in summary, some of the things that I hope you came away with in this webinar are basically talking about understanding the occurrence and the prevalence of black triangles, proper case selection and management for black triangle treatment, especially with the black triangle kit, and the benefits of injection molding and the BioClear method. Certainly the benefits of using preheated composite resin, which is critical for injection molding. And then also the steps and of the Rockstar polishing method, and then the benefits of recreating a mylar finish to your composite resin restorations as far as aesthetics and longevity. So I want to thank everyone for joining me today on this webinar. I hope to join you again on a different topic. Thank you for your time.